All right, let's just jump right in. Today's explainer is a total masterclass on managing TBM, tuberculous meningitis, hydrocephalus. We're going through this point by point, skipping absolutely nothing, so you won't even need to crack open the textbook after this. We're getting into the pathology, the grading, and the exact surgical decision trees.
Here's the roadmap. We've got basics in pathology, the Vellore grading system, EVD protocols, ETV and shunting variables, and finally we'll tie it all together with a management algorithm. Let's go.
Section 1. Basics and Pathology.
So hydrocephalus is basically one of the absolute most common complications of TBM, right? It can pop up before, during, or even after treatment. And what's actually happening is these incredibly thick, gelatinous inflammatory exudates physically block the CSF pathways. This traffic jam can happen down in the subarachnoid cisterns or straight up in the ventricles themselves.
Now, look at this demographic split because it is staggering. In kids who've had TBM for about 4 to 6 weeks, hydrocephalus hits an overwhelming 87 to 95% of the time. But in adults, it's only about 12%. It's a huge difference. Oh, and keep in mind, late-onset hydrocephalus is totally a thing too.
Depending on where exactly that gelatinous gunk blocks the fluid, you're looking at a few subtypes. It could be communicating, which usually shows up later, non-communicating, which hits early, or just a mixed bag. But here's the real clinical pearl. Not every patient actually responds to hydrocephalus treatment. The clinical picture is super multifactorial. That means your foundational medical management, we're talking antitubercular therapy or ATT, steroids, and diuretics, is absolutely crucial.
Moving on to Section 2, the Modified Vellore Grading System. When we're talking clinical decision-making, the Modified Vellore Grading System, or MVG, is literally your cornerstone. Why? Because a patient's MVG grade right at presentation is hands down the most consistent predictor we have for how they'll do after a shunt. As you'd guess, the lower the grade, the better the outcome. Let's break down exactly what these grades look like.
All right, looking at the milder presentations, grades I and II. In both of these, the patient has a totally normal sensorium, so a max GCS of 15. The catch? Grade I patients might have a headache, vomiting, fever, maybe a stiff neck, but absolutely zero neurologic deficits. Grade II patients, on the other hand, do have a neurologic deficit. But honestly, the tracked data shows both groups typically have really solid outcomes, usually landing on good recovery or just moderate disability.
But as we move down into grades 3 and 4, things get dark pretty fast. Grade 3 patients have an altered sensorium, GCS is sitting between 9 and 14. They're easily arousable and might or might not have dense neurologic deficits. Then you hit grade 4. These patients are deeply comatose, GCS 3 to 8, and they're showing decerebrate or decorticate posturing. The mortality rate here, it skyrockets. In the specific data sample from our sources, 14 out of 27 grade 3 patients died. And for grade 4, all 7 patients in that particular sample tragically did not survive.
Section 3. External ventricular drainage, or EVD.
So, EVD plays a super specialized role depending on the patient's grade. For our grade 3 patients, clinical status can tank really fast. If an MVG3 patient is deteriorating and you desperately need urgent CSF diversion, but a definitive shunt just isn't immediately possible, you go with an emergency EVD. It's essentially a critical, temporizing bridge, a way to keep them stable until you can safely get that shunt in.
Now, the actual protocol for grade 3 is honestly kind of counterintuitive. You'd normally think, hey, let's see if they improve with the EVD first before we commit to a permanent shunt. But the data actually shows that for grade 3, how they respond to an EVD doesn't really correlate with their final outcome. Because of that disconnect, the recommendation is simply definitive shunting for all grade 3 patients, period.
But for grade 4, our deeply comatose patients, it's a completely different story. We use a very strict 48-hour rule here. The evidence is absolutely clear. If a grade 4 patient doesn't improve with an EVD within 48 hours, they are not going to magically improve with a definitive shunt. So the protocol mandates placing an EVD for up to 48 hours first. We only pull the trigger on shunting if there's a demonstrable, positive response in that specific window.
Section 4. ETV and shunting variables.
Let's unpack endoscopic third ventriculostomy, or ETV, and the permanent shunting options. A lot of folks view ETV as the go-to long-term fix, and it does have a solid 41 to 81% success rate in TBM hydrocephalus, but it comes with massive caveats. First off, you absolutely need an experienced surgeon. Remember those thick exudates we talked about? They can thicken the floor of the third ventricle and completely obliterate the subarachnoid space. Trying to navigate that thickened tissue shoots the risk of a catastrophic basilar artery injury way up. Because of that, ETV is still super controversial during the acute phase or for communicating hydrocephalus.
If we dig into what actually makes an ETV successful, there's a really interesting, statistically significant trend. Patients who had a successful ETV had a median TBM duration of 4 days. In the unsuccessful group, only 1.5 days. That basically tells us that a slightly longer duration of the disease before you intervene actually correlates with better endoscopic outcomes.
And check out the difference in pre-op medical management. Patients with successful ETVs had a median pre-op ATT duration of a full 30 days. The unsuccessful ones, just 1 single day. While the sources note this as more of a trending factor rather than strictly statistically significant, it's a huge indicator that a robust stretch of medical therapy really primes the patient for a win in the OR.
So, when it is time to place a definitive shunt, we have to ask a huge question. Do we route that cerebrospinal fluid down to the peritoneum, a VP shunt, or over to the atrium of the heart, a VA shunt?
Well, with tuberculosis, the answer is crystal clear. VP shunting is definitely the preferred route early in the disease. Yeah, sure, some studies argue VA shunts are safe, but the overarching, massive concern is hematogenous dissemination. If you route that infected fluid straight to the atrium, you are literally risking pumping the tubercular infection right into the bloodstream, spreading the whole thing systemically. Nobody wants that.
And timing? Timing is everything. Once you make the call to shunt, you cannot drag your feet. Getting that shunt in just 2 days after the decision gives you significantly better outcomes than if you wait 3 weeks. It's literal brain-saving stuff. The only slight exception is if you've already got a temporizing EVD in place, which buys you a little more time.
Also, the type of hydrocephalus totally dictates your urgency. Obstructive hydrocephalus, that's a huge, flashing neon sign to shunt immediately. Now, if it's a communicating type, you could make a case for trying strictly medical management first. But listen, if you go that route, you have got to use intense, continuous ICP monitoring. If you don't, you run a huge risk of the patient suddenly deteriorating and suffering irreversible neurological damage.
Section 5. The management algorithm.
Okay, let's tie every single grade, rule, and variable into one incredibly practical algorithm. A TBM patient with hydrocephalus comes in. First thing, you grade them. If they're MVG grade 1 or 2, boom, straight to an early VP shunt or ETV. If they're grade 3, you ask, is it an emergency? If yes, pop in an EVD, then transition to a VP shunt or ETV. If it's not an emergency, just go straight to the definitive shunt. But if they're grade 4, that's where we hit that strict 48-hour EVD trial. If they wake up a bit and improve to a grade 1, 2, or 3, they get the shunt. If nothing changes, you pull the EVD and pivot exclusively to conservative treatment and ATT.
So, as we wrap up this explainer, I really want to leave you with a provocative thought. We've just walked through this highly structured, data-driven pathway. But think about that razor-thin margin of error for those deeply comatose patients. Does a strict 48-hour window for MVG-IV patients actually perfectly balance the risk of a futile surgery against the nightmare of irreversible brain damage? It is a massive clinical burden to carry. But hey, armed with this data, it's a decision you can make with absolute precision. Thanks for walking through this masterclass with me. Keep exploring, and I'll catch you next time.